A very good evening and warm welcome to all the dignitaries present here. I am Momita from Clinic, serving as the allocated station assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as the digital partner for this event, hosted by the Indian Radiological and Imaging Association Bihar chapter. And the focus of today's session is the pathophysiology and imaging in fatty liver. So without any more delay, let's begin to the session for which I would like to invite Dr. Riju Matthews sir to take over. Over to you, sir.
Thank you, Mamita, and a very warm good evening to each one of you who have joined for this first session of the Preventive Radiology Asia in association with IRA, Indian Association of Radiological and Imaging Association, Bihar State Chapter, and along with the Global South Alliance for Safe Motherhood. And Preventive Radiology is a new branch of radiology which has been introduced by Indian radiologists apart from the diagnostic radiology and interventional radiology. And what we would like to explore in this new branch of preventive radiology is the role of radiology biomarkers being integrated into the high-risk group stratification for non-communicable diseases and cancers. So this is a totally new area, a new domain that is being explored by the Indian radiologists within the larger realm of preventive medicine. So one has we have focused on areas of radiology biomarkers in respect to preventive radiology, that is radiology biomarkers of metabolic dysfunction, radiology biomarkers of endothelium, radiology biomarkers for early cancer detection, and radiology biomarkers of target liver and kidneys. Radiology biomarkers will be increasingly used in the coming years within the larger realm of preventive medicine by integrating the radiology biomarkers in the branch of preventive radiology. So one area that we have focused for the last 2 years, ever since the preventive radiology was conceptualized and introduced. It was introduced by Indian Radiological and Imaging Association during the presidential year of Dr. Professor C. Amarnath in 2021. And ever since, we have focused on one emerging area, which is one emerging epidemic of fatty liver disease. This is something that radiologists have been seeing for the last 25 to 30 years. And of late, we have seen that fatty liver disease is not that innocuous, and it has got serious implications that leading to cirrhosis, where now 3 out of every 10 liver transplants in most of the major cities are due to metabolic dysfunction related fatty liver disease, or which was previously called as NAFLD, or non-alcoholic fatty liver disease. So this is a very important topic that has to be discussed, but radiologists were the first people who have identified this fatty liver disease. But of late, we have not paid much attention to it because this has been underestimated by the use of a routine ultrasound abdomen, and we often feel that that is not the kind of attention that it requires, because the kind of prevalence of fatty liver disease and the complications, if we don't act this window of opportunity, the entire healthcare system need to train more and more surgeons to do more and more liver transplants. So this 20 years is a window of opportunity for radiologists to create this awareness, to do screening for the people who have come to us for in our routine ultrasound with fatty liver disease, for further evaluation by using liver elastography, the liver stiffness values, etc. To talk to us about this today, we have an eminent speaker who has done a lot of work on this area, especially Dr. Sharat Maheshwari. He is a consultant from Kokilaben Hospital in Kokilaben Ambani Hospital in Mumbai. And he has been working on this particular area for the last 15 to 20 years and has done extensive work on MR elastography, and especially on the radiology biomarkers of metabolic dysfunction. He has got a large work that is being carried out and a lot of publications too. Apart from Sharad, I have the panel Dr. Venkatesh Kashi from KMCH, Kobe Medical Center, Coimbatore, and Dr. Anjali Gupta from Agra. Both of them will be joining as panelists. To moderate this session along with me, I have the pleasure to introduce Dr. Praveen Nirmalan, who is a Chief Research Mentor at Amma Healthcare Research Curricula Unit of Amma Center for Diagnosis and Preventive Medicine, Cochin, who has got a master's in public health from John Hopkins and is a mentor for our Samrakshan program as well as for the preventive radiology program. But to give the opening remarks here, I have got the pleasure to invite Professor Dr. Ashok Kumar Mandal, sir, who is a past National Vice President of Indian Radiological and Imaging Association and a senior leader of Indian Radiological Imaging Association from Bihar, to give the opening remarks for this particular program. Over to you, Mandal sir. Welcome, Mandal sir, and I request you to give the opening remarks for this session.
Okay. Good evening to all of you, sir, and to delegates also. The Preventive Radiology Initiative of IRA is the national initiative that focuses on expanding the integration of clinical radiological services with preventive medicine for early identification, prognostication, and intervention for clinic priorities in India. The program is conceived and established by Dr. Rijo Matthews Churakotil, who is the national coordinator for this initiative and was initiated during the presidency of Professor Dr. C. Amarnath with the wholehearted support of IRIA. Please come and make this program effective in future to save our people. In this year, on the day of World Health Day, the slogan is My Health, My Right. It fulfilled if we take care of our living societies, for particularly there are so many cases of fatty liver. In PSM workbook, in the chapter of geriatrics, we read, old is preventable, not curable. Same things happens for the liver. If all of us make it efforts to save our liver for future, then it helps to our community better. Thanks. Long live IRA and ICRA. So we are.
Thank you, Mandal sir. Let me invite my co-moderator, Dr. Praveen Nirmalan, to give some comments before we start the program, and I would like to invite Dr. Sharad Maheshwari to take over the lecture after Praveen Nirmalan's remarks.
Sure. Good evening, and sorry, Sharad, to keep you waiting, as well as for the audience to wait. Preventive radiology is an area that we are developing, that Dr. Rijo has worked on, conceptualized, and that we are developing. And in a certain aspect, it is quite a, if I can say, a misnomer. The radiologist has always been an integral part of preventive medicine, even though the radiologist has not always recognized their potential, as well as the fact that they are an integral part of preventive as well as clinical medicine. For some reason, most radiologists believe that their role has been to focus on imaging, on images and interpretation of images, while taking a step back from their prime potential of being the fulcrum around which both preventive as well as clinical medicine can function. There's been a movement towards that in terms of looking at radiological and imaging biomarkers, similar to how you have biochemical markers, you have other markers for conditions. And that's an important aspect, especially when we consider the large term magnitude of non-communicable diseases, the links between different non-communicable diseases, especially those related to the metabolic dysfunction spectrum, and how they interplay and impact upon each other, and how imaging biomarkers can provide an even earlier identification of these conditions much earlier than biochemical biomarkers and in a more less invasive, non-intrusive manner. For instance, we had started a program on non-alcoholic fatty liver disease, and we had looked at the liver stiffness measures and what we using ultrasound shear wave elastography. And what we found is that 1 in 5 of those who participated in that particular program as part of a wellness initiative, in terms that they did not feel that they were symptomatic, they did not feel that they had a disease, they were not referred for any clinical condition. 1 in 5 of them had an LSM that was ranging, liver stiffness measure that was ranging towards a chronic compensated liver disease, which is a high magnitude. So most of them were 30 to 60 years old also. So in terms of the ability to use radiological imaging biomarkers to identify early conditions, even in an apparently normal population, which is also the demographic that we are slowly dealing with. 30 to 60 is the age group that's slowly building up, while the younger demographics are lowering as our fertility rate is lowering. So we are going to see more and more of 30 to 60s as well as post-60 population coming in. So catching them early, using painless, easily accessible, affordable, non-intrusive measures is something that can help reduce the burden of interventional procedures at a later stage. And that is one area where the radiologist can play an integral role, and it's one area that the radiologist must waken up to. If I say undiplomatically, rather than focusing so much on turf wars and turf expansions, you must grab hold of the turf, reclaim it, and make it yours and own it. And this is an area that you can. This is an area that's integral to what you're doing. And it's only a matter of now rechanging the paradigms to think in terms of being a clinician as well as a preventative specialist, as well as a radiologist. So with that, I would like to invite Dr. Sharath to start this session. Dr. Sharath is a young, dynamic, engaging speaker with a vast wealth of experience and a wonderful set of teaching and learning inputs that are very, very useful for clinical practice. So I would advise all of you to listen very carefully to him and feel free to ask as many questions as you want. Dr. Venkatesh from Coimbatore and Dr. Anjali from Agra are more than happy to join with Dr. Sharath to answer all your questions. So make sure that you understand as much of this subject as you can by the time this session is over. With that, I hand over to you, Sharath.
Thank you so much, sir, for the nice words. And I think we are now a combination of preventive social medicine, internal medicine, and radiology. So we have to take care of 3 specialties. I'll just share my screen.
Yep.
Okay. So I'm visible, my screen. Everyone can see my screen?
Yes.
Yeah.
And I'm clearly audible.
Yep.
Okay. So it's an interesting topic, very close to my heart. So I'll talk more about pathophysiology today, because as a radiologist from the first year itself for residency, we know how to identify fatty liver, but we need to understand how critical it is now for patients. So the objective of my presentation is, first we'll know what is liver steatosis, what does to the liver, where does it lead to, and what is our role as a radiologist. So before we move to the presentation, let me introduce the nomenclature. There's a very recent update a couple of months back. So the terminology has been changed now. Fatty liver disease is called as steatotic liver disease, and fatty liver due to metabolic was always called as non-alcoholic fatty liver disease. So they didn't wanted to keep the alcohol thing. And I think adding the word metabolic makes sense. So it becomes metabolic dysfunction associated steatotic liver disease. So what was NAFLD now is MASLD. And when fatty liver becomes associated with inflammation, then it becomes steatohepatitis. So it is called as metabolic dysfunction associated steatohepatitis. Short form is MASH. So, as Dr. Rijo said, we have a window of 15 to 20 years before fatty liver becomes cirrhosis. But unfortunately, there are other factors which play into. And so now we have a new category where people have metabolic disorder and plus they are taking alcohol. So it is like acting like a catalyst. So this new category is MET ALD, where you have fatty liver disease due to metabolic disorder, plus alcohol is also adding to the problem. And so we all are moving towards the obesity thing, as in lifestyle is improving. So let me start with a case. This is a scout image. As you can see, this is a obese lady. So she had very non-specific symptoms, have been going to GP, and then finally she went to a gastroenterologist. So considering her body habitus, instead of ultrasound, we sent the patient for a CT scan. And so she didn't have an ultrasound, directly a CT scan. And what we see is that this liver was quite fatty and the margins were nodular. And at the same time, we saw a focal hypervascular lesion in the segment 6 of the liver. And this patient had, on probing further, we found that she had hysterectomy for endometrial CA. So what we have here is a diabetic obese lady who had hysterectomy for endometrial CA. She has a liver cirrhosis due to fat. There is a HCC as a presentation, and also she has stones. So this is nothing but an epitome of a metabolic syndrome, a classic example. So what we are looking at now is an epidemic of metabolic syndrome. It has obesity, high blood pressure, dyslipidemia, and insulin resistance. And the epidemiological profile, viral hepatitis used to be a #1 cause for liver disease, but now it is reversed. Fatty liver disease is the #1 cause. Alcohol remains second. Viral hepatitis take the back seat, especially with vaccinations. So for our Indian population, like we are the diabetes world capital, understanding insulin resistance is very important. So it is nothing but that our cells have a reduced ability to absorb blood sugar for energy. So this leads to more insulin secretion than what is required, a pre-diabetes stage, which then progress to diabetes type 2. And insulin resistance, diabetes is linked, is a multi-factor, like it affects multiple systems. So diabetes leads to cardiovascular disease. It leads to fatty liver disease. Fatty liver disease itself promotes cardiovascular disease, and then there is an increased incidence of cancer. So they are all interlinked. And interestingly, the most common cause of mortality in patients with fatty liver disease is cardiovascular disease. So it's time cardiologists have to think little bit like hepatologists too. So if you see, the prevalence of fatty liver disease is much higher in obese patient. Like in general population, this orange color is very less, but then it increases significantly in obese patients. This is tip of the iceberg, like an Indian story. So around 16 to 32% of Indian population has fatty liver disease. So out of which 1/3 are steatohepatitis. 6.3 crore people are type 2 diabetes, because this is the number from where the data is available, but in villages there's no testing, so this number is much higher. So out of 6.3 crores diabetic patients, 4 crores have fatty liver disease. And out of this 1/3, that is around 1 crore people have steatohepatitis, the second stage when there is inflammation. And out of this 1.3 crores of NASH, 5% will develop HCC. So we are looking at a staggering 6.5 lakh patients of liver cancer. So this is the spectrum of the disease. Fatty liver disease is nothing but fat get deposits within a hepatocyte. So you have a normal liver which becomes simple steatosis, or then there is a second stage where inflammation sets in the liver. So typically in a biopsy you see neutrophils, and this is called as MASH, steatohepatitis, and then that progresses to cirrhosis, and then once you have cirrhosis you have a higher incidence of HCC. Now what is interesting, even if you just have fatty liver, it may not have any inflammation, you are at risk of HCC. If you get inflammation, steatohepatitis, your risk increases by 10 times. And if you become cirrhosis, then even further incidence. So some people are saying that even that fat itself in the liver is acting like a carcinogen. Now, one of the way of identifying patient with steatohepatitis is if you do the LFT, the SGOT, SGPT will rise. But then there are a lot of patients whose LFTs are normal. So just relying on LFT is not enough. This is an example of a fatty liver disease patient. There is severe fatty liver, and you can see the liver is little bit abnormal as well, like prominent fissures, but all the LFTs are normal. So if we do screening, mass screening, and rely on LFT, we will go wrong. Now, I think this is the same thing. The risk, when you have these factors, the risk of developing cirrhosis is very high. One is type 2 diabetes. Second is obesity, BMI of more than 30, age more than 50, and AST, ALT rising by 2 times of normal. Now let's come to the pathological aspect. So what is liver steatosis? So let me show you, this is a normal hepatocyte, and that is the nucleoli. While if you see this hepatocyte, there is a white bubble inside it, and this is the fat droplet, the lipid droplet, which is inside the cell. Now, this fat is called as microscopic fat because it is in the cell and you can only see it on a microscope. While the fat you have in mesentery and omentum is a microscopic fat. Now, this is a schematic. That's the nucleoli, that's a hepatocyte, and this white droplet is the fat. Now, here the fat droplet is very small. So it is called as microvesicular fat. While in this hepatocyte, the nucleoli is pushed to one side because the fat droplet is big, and that is called as macrovesicular fat. Now, to see this microscopic fat, you need MRI imaging. Coming to the second step, where you have first step fat in the liver, then gradually the fat creates an inflammatory environment, and that leads to neutrophil infiltration, and then gradually it moves to fibrosis. So there are something called as stellate cells, which are the key factor in causing fibrosis. Will not go into that. Now, simple fatty liver to steatohepatitis. There are three criteria to call steatohepatitis. One, there should be fat. Two, there should be inflammation as marked by neutrophils. And third is ballooning of the cells. Now, let me give you an example. You have a tent and it has a bamboo structure in it which is holding the tent. Now, if this bamboo structure is broken, the tent balloons out. So same thing, a hepatocyte has all other organelles. It has mitochondria, Golgi bodies. So there is a cytoskeletal structure framework. Now, when this fat starts occupying the cell, it distorts the internal architecture, and then the cell is moving towards cell death. So that stage is ballooning. So let me show you how a hepatic lobule is. So a hepatic lobule is a hexagonal in shape, which has a central vein, and in the hepatocytes, in the hepatic hepatic lobule, you have multiple hepatocytes within it radiating out from the central vein. And these are the portal triads where you have bile ducts, artery, other structures. And this is our hepatocytes. They are linear arranged in palacytes. Now, histopathologically, the fibrosis grading is done by, which is called as Metaver grading. So it is F0 is no fibrosis and F4 is advanced fibrosis cirrhosis. So F1 is a stage where there is more of inflammation and very little fibrosis. Stage 2 is when fibrosis is now spreading inside within the hepatic lobule. F3 is when the fibrosis starts extending into the portal triad. So now you see here the architecture, at this stage, the architecture was stable, but here the entire liver architecture has started to distort. And then finally, we lead to a stage where there are large fibrotic bands in the liver, and whatever intervening liver is left is the regenerating nodules, because the liver has an ability to regenerate. And this is stage where every liver cell has a potential to become cancer. So I'm sure you all have seen cases who have multicentric HCC. And even if they develop a single HCC, they keep on developing HCC at other sites. So that is why once you are a cirrhosis, there is a screening program where you do ultrasounds every 6 months and cross-sectional imaging annually and 2 years gradually. There's a program for it, which varies from place to place. So what are we? We are the gatekeepers. We are the first people who identify fat, and we just can't leave it there. So we have a responsibility here. So our role is first to identify the fat, Number two, quantify it. If you're doing ultrasound, mild, moderate, severe, if you have a CT scan, you can measure the Hounsfield units. So this is normal ultrasound and this is abnormal where there is fat. Now the one problem with ultrasound is a lot of these patients are obese and we have a limited posterior visibility. So if you see such a patient, it is better to suggest cross-sectional imaging further. Now, Dr. Rajas, we do preventive programs and Dr. Rajas is always there. So there are now quantitative methods also on ultrasound, newer machines where you take values from the liver and the kidney and they are able to quantify it in a better way. So I am sure in one of the sessions, Dr. Rajas will take that also. On CT, what we do, it is called as the liver attenuation index. And you take ROI measurements from the liver and you take ROI measurement from the spleen. Typically you take 25 measurements in the liver, create a mean. So if, say for example, the mean of the liver has come as 50, and then you take 9 measurements from the spleen, you create a mean. Now, suppose this liver is 55, liver is 50 and spleen is 55, then liver minus spleen. So the liver attenuation index becomes -5. If the liver is 40, spleen is 55, the liver attenuation index is -15. So anything more than -10 is a significant fat. So this is the most common technique used for identifying donors for liver transplantation. So any donor which has fat more value of more than -10 is rejected and not taken for potential liver donor. Coming to MRI, as you see, there is subcutaneous fat, there is fat in the mesentery and omentum. This all appears bright on the T1 weighted image. So this is the microscopic fat. But the microscopic fat we cannot see on a routine sequence. Why is it so? On the in phase, the fat and the water, they are precessing in the same direction. So they add to the signal. So what we do is we do a set of the chemical shift imaging as a 2 set of images, the in phase and out phase. I'll not be going much into the physics of this. So what happens? The fat signal and the water signal cancels each other. So then you see a signal drop in the liver. So that's how you identify microscopic fat, the fat in the hepatocytes. So you can see because there was so much significant fat, the overall signal of the liver was slightly brighter than what you expect. And this is a signal drop which confirms that there is fat in the liver. But then we need to quantify. So the chemical shift imaging then came another sequence which we call as Dixon. Dixon is also chemical shift imaging, but then it gives a 4 set of images: the in-phase image, out-phase image, the fat image, and the water image. So you can create ROIs and put it in this formula, and you can get a fat percentage. But there was a problem by making ROIs and calculating fat on the Dixon sequence because there were certain confounding factors. You all know when there is those who ever do MRI, whenever there is iron in the liver, it causes T2 star effect and the liver becomes dark. So this T2 star interferes in the fat quantification. And why this is important, let me tell you. that fatty liver disease, when becomes advanced, the liver starts getting more iron in it. So you will have patients where iron is not allowing you to do a proper quantification. Another thing is this sequence was not good enough to accurately separate water protons and fat protons. And thirdly, fat is complex. When you do MR spectroscopy, you will see that fat has multiple, there is one predominant peak, but there are multiple other peaks also. So when you're quantifying the fat, you just can't quantify this. You need to take consideration of other peaks also. So now the current MRIs scanners have this sequence which is called as proton density fat fraction, where it takes care of all the confounding factors, and it gives you a true ratio of the fat protons and the water protons. So it is a MR biomarker of hepatic steatosis, and it is quite accurate. It is validated on multiple studies. It is gives you precise numbers, and it is reproducible. So you can do that patient multiple times, and you can rely on the values. Of course, there are some technical aspects which you have to take care of. So it is the same Dixon sequence, but then it had only two in phase and out phase, two echoes. But this one is a multi-echo Dixon, which has like 6 phase, 6 different time echoes are used. Now the vendors have made it easy now. While scanning, you just create few ROIs, and once the scan is done, you get a colored image like this, where it has the percentage and scale. So it becomes very easy. You can, it comes with a fat percentage. And interestingly, this sequence also gives you the iron content. So yeah, you are able to give a quantification fat percentage, and you are also able to give how much iron there is in the liver. So if I have a fatty liver patient who has a higher iron, I know that this patient is going towards an advanced disease. Now, MR spectroscopy has been available for many years, and it is a gold standard. It is even better than doing that PDFF sequence. But then the problem with MR spectroscopy is you can just do one voxel, and every time you have to check fat, you may end up doing 10 times the same MR spectroscopy. Whereas the multi-echo Dixon, it gives a and coverage of the entire liver. And if you want on retrospect, you can go on the workstation and create as many ROI as you want. So the scanning time is significantly reduced. So MR spectroscopy is what we do is we do the PDFF and choose one or two sites and do a MR spectroscopy also. So I have a gold standard in case I find there is variation in my PDFF results, then I have a gold standard MR spectroscopy. So this way we get best of both worlds. So there is a big window before cirrhosis is diagnosed. If you identify fat, then you have to identify early signs of chronic liver disease, and you try to detect occult fibrosis. Now, to detect all this, the gold standard is liver biopsy. But remember, biopsy is invasive. You cannot apply to a large population. And imagine you're sampling 1 in 50,000 of the liver volume. And the fat can be geographic, it can be diffuse, but fibrosis is always heterogeneous. It is never same at all the time in everywhere in the liver. So when you biopsy liver, there is possibility you may be biopsying from a place where there is F0 fibrosis, and there may be sites which are F4 fibrosis also. So shear wave elastography is the answer which you use for identifying occult fibrosis. Which why I'm saying occult, because advanced liver cirrhosis you can make out on your ultrasound or a CT image by the abnormal morphology and nodular margins. But there is a stage where fibrosis is started, but the liver still has smooth margins. So MASH cirrhosis is little different compared to other cause of cirrhosis like viral hepatitis. Why? Because it's a very slow process. The fat starts depositing, mild, moderate, severe, and the fibrosis happens over a long time. So initially the liver becomes enlarged. You can see the right lobe going downwards, the caudate lobe is enlarging, getting more rounded. But over the time, when cirrhosis starts setting, the liver starts losing fat. So this is how advanced fatty liver disease would look like. If you see this contrast image, you can see that the liver surface is smooth. You can't make out any nodularity, and the enhancement is also homogeneous. So you may call this as normal liver, but then if you look carefully, the liver is little rounding, lumpy, bumpy. But if the same, I do a 3D reconstruction, I see a very abnormal, lumpy, bumpy liver. Also show another example. If you see this liver, it is normal. If you see here, I would still might call this as normal. There are smooth margins. But when I look at the coronal, you see here the liver is enlarging everywhere. And on a 3D, this is how a normal liver looks on a 3D image, and this is how a chronic liver disease patient looks like. So this patient is not full-blown cirrhosis, but it is already going into like F2, F3 fibrosis. So this surface nodularity is something which happens in the end. So if we try to just look at the nodular surfaces, the window will be lost. So it is at this stage that we have to catch things. Some another example of a abnormal looking liver. This patient also came for the first time for cross-sectional imaging, and with the fatty liver, he presented with a hypervascular lesion. There was a concern for HCC, obviously, but then this turned out to be adenoma. But adenomas are known to happen in fatty liver, and they are pre-malignant. This is an example. This is a patient we did scan in 2012, 16, and 17. Initially, the patient was fatty. The LAI is -15. In 2016, the LAI become +4. So liver starts losing fat. You see the surface is still smooth. And next year he comes for an MRI, and we see that MR has a higher sensitivity to look at the parenchyma abnormality. So this liver was definitely abnormal. You can have other causes of fat like chemotherapy. Now that cancer is gradually moving as a cancer is gradually going to be chronic liver disease. We have very good results in breast cancer, colon cancer. So these patients get chemotherapy and they live for like 15, 20 years. And chemotherapy causes liver damage as well, and it can lead to liver cirrhosis. And this has seen quite often compared to other cancers in breast cancer, because they get maintenance therapy, which is known to cause liver damage. Uh, Alcohol is the second cause, and alcohol cirrhosis is also a reality. And now imagine we have a patient having diabetes, taking alcohol, and then get some malignancy, gets chemotherapy. What's going to happen? So no, this is the second part of my talk, which is elastography. So that is itself a bigger separate talk. So I will stop here. I hope I gave you a fair idea on what exactly fatty liver is and how it affects the liver. Over to you, sir.
Thank you, Sharath. That was a very informative talk
Thank you.
and quite a lot of good points that were covered in it. Relevant points, especially as pathology is the foundational basis upon which clinical improvements can occur. And unless we really understand the pathology, we're really not going to move too much further with clinical interventions or with clinical progress, newer modalities and things like that. There was a question that came in from the audience. When should we advise MR evaluation?
Okay. So actually, if you want to do fat quantification, MRI is the investigation of choice. Uh, the uh, the fat values which MRI gives, they are better than biopsy, because I said biopsy just samples a small area. And other thing is, pathologists, when they are looking at the slide, they are giving a subjective answer. They just look at few, means they can't count the cells in the slide. So they give a semi-quantitative answer. While on MR, we are giving actual value.
To follow up on that, one important thing that came from your talk and something that we constantly face when we talk about the liver is the fact that the liver biopsy actually samples a very small portion of the liver, and it can still be a hit and miss depending upon the part of the liver that you have sampled. It is painful, it is invasive, it has its own complications, and yet we often see that the biopsy is still considered to be the holy grail or the gold standard by which any new change has to be evaluated. Is that realistic and pragmatic to focus on the biopsy as the gold standard in this changed environment, or should the gold standard shift to MR, given the nature that MR findings are almost as similar, if not better than biopsy, and it's easier to do?
So actually, at the end of the day, pathology becomes the gold standard for everything. But if you see the liver transplant centers, they have stopped doing biopsies. So gradually that thing will go into other practices also. But as of now, the liver transplant groups, they have stopped doing biopsy. So I think we can take their confidence into us, that they are confident about these values.
Yeah, as Dr. Sharath said,
Yes.
in our center also we're doing a lot of liver transplantations, and we completely stopped liver biopsy for quantifying the fat.
Right.
And there are so many literature has come out to tell that MRI PDFF can be considered. It is equivalent to that of the biopsy.
Yeah,
And
it's
we
a
are,
surrogate
yeah,
for biopsy, surrogate marker.
exactly. And we are having a lot of advantages, other advantages also. We are evaluating the entire liver. We are identifying which portion of the liver is fatty. So for the living donor, whether it's a right lobe is involved or left lobe is involved, so how it will affect the outcome of the patient. So all this will be identified with the MR.
Yeah.
But the important point in the
Right.
preventive program, if you want to take it, we have to identify the parameter in the ultrasound.
Right. So, Dr. Rajas, maybe next time
Yeah.
him also. So, what I heard in his talks, now they are taking measurements to the liver, kidney, and coming out with a score.
Yes.
Yeah.
There are there are 2-3 parameters as we know. First is the just a qualitative, just seeing the echogenicity.
Yeah.
Now the semi-quantitative parameters are as we discussed the hepatorenal index and other scores. Now there are so many other parameters which can quantifying parameters has come out. Something like attenuation imaging,
Index.
Yes.
which exactly identify the amplitude of the ultrasound and the speed of the sound, estimation of sound speed estimation. So these are the 2-3 parameters which are coming out now in many newer machines. They come out and they are also trying to correlate with not with the liver biopsy, they are trying to correlate with the MRI PDFF.
MRI.
PDFF. So when they compare, and most of the time they are able to find out, they are able to quantify with the ultrasound itself. If you're going to get a good amount of literature in that, then we can use that for the preventive program. Very well, we can use it.
So that's true. We should focus on ultrasound, but wherever we feel this is inadequate, I think we should simply further recommend a CT or a MR.
MR.
CT
You
is,
should not hesitate.
majority of liver transplant programs still work on liver attenuation index. So
Yes.
liver attenuation index, like thousands and thousands and patients have gone through. So if the cost is a factor, you don't have to do MRI. You can maybe plan limited liver CT to get an idea.
Yes. That's also true.
So another thing I wanted to emphasize upon is that we, as a preventive or in preventive medicine, our focus is also to monitor the progress of disease progress with the vis-a-vis response to therapy. So you cannot always have say a biopsy for that. So you need non-invasive, and for
Yes.
that, even for monitoring response, if we are able to quantify fat on ultrasound, that will be better, because MR is a bit expensive for the patient for follow-ups. So maybe for the primary diagnosis, and there are studies, there are many white papers, especially from vendors like maybe Samsung. Also, I have a Samsung machine, so I have those white papers. And they say that there's a good correlation between the attenuation index and scatter index. They measure hepatorenal index is one thing which they measure. And then there is tissue attenuation coefficient, and there is a tissue scatter, back scatter they measure, and they correlate very well with the MRI PDFF. So there are papers in the literature, and maybe we need our own studies for that to potentiate. For that, the patient has to undergo an MR, and so maybe possible in institute levels.
So whenever you feel I got this answer on ultrasound, but I think now I need a biopsy. So that is the time where you do an MRI.
Do an MRI.
So
Yeah.
we are also considering, because if you do a liver MRI, you may take 25-30 minutes. But if I have to do just PDFF, it is possible to do
It's
the
another
scan in
5
less
minutes.
than 10 minutes.
Yes.
So
So
we
that's
can,
a cost can
so
be
we are
reduced.
considering a low cost order to
Scenario.
be created where, few thousand rupees we can just do the fat quantification.
So that'll be great for the patients.
And the availability of the MRI.
Therapy
So then
is
we need
involved.
to have a protocol across the country, like for a fat estimation or something like that. We can do it through IRIA, and have a maybe this thing can be done in the future.
The
So that's a
liver,
good point.
the fat and the liver is a priority area for the government of India as part of the expanded NCD that they have built in. But their primary focus has been on the use of fibroscan, fibration, central elastography, and
That's a
they're not
blind
good
thing.
beyond that. But they've put that
gastroenterologist.
out as a priority area for this. And they have also initiated several training programs that they want at state levels.
The
for that. But
gastroenterologists are not interested in ultrasound as a screening tool for elastography. They're still focused on vibration.
They won't give that. So there was a big
Because
fight
that is
was going
because the
in my
radiologists
institution. In a journal club, there was a big.
I think that's because the radiologists have not
Yes.
actually promoted the use of both MR or ultrasound as well as they should have. You see that ground there, you found that easier to do, they're going ahead with that. We can't argue with that. So we need to reclaim that ground by bringing up evidence that says that it is equally good, it's even better. And we need to bring that out in a very scientific manner that can then change the whole level of discussion and get them back.
The papers
Right.
should come out.
Yes, that's something that we have to be very active on. There's one question that is here. What should be advised to grade 2 and 3 fatty liver?
On ultrasound. MRI.
Now, what I am doing now, if I see fatty liver, now sometimes I feel that instead of me just deciding on the test, I say suggest consultation with gastroenterologist. So either I can say do LFT correlation and MRI or send the patient to gastroenterologist. So I do both ways. If I feel there are little advanced features, I say suggest consultation with gastroenterologist. So they can, have a. So I think so we have, since I am in an institute, it's very easy. You have 3 gastroenterologists to deal with. You convince them, you talk to them, and since they are also in a teaching institute, they also have students. So we have come across and have a plan how to deal once we see a fatty liver. So they also don't mind referring patients to us, and we don't mind to referring to them. But once you go in a private practice, the dynamics changes completely. So that can be a different ball game. But in my institute, I am writing refer to gastroenterologists.
As far as we are concerned, we are private standalone practitioners. So I am practicing mainly ultrasound. What happens is when the patient is with you for say 5 minutes to 6 minutes, you're talking to the patient continuously. So you can offer a lot of counseling to the patient. So stage 1, this thing, fatty liver grade 1, we can counsel them about lifestyle modifications. I do them. I make them promise me to come back after 3 months after lifestyle modifications, stopping all maida and doing a little bit of cardio and everything, and get their these LFTs done. And they comply. Many times they comply. If they're coming through a physician, then I don't do that. But if they're coming from any other stream, doctor, or they are self-referred, then I go ahead and counsel them. And they return after 3 months and they are very thankful that you opened our eyes or things like that. For grade 2, grade 3, I send to the gastroenterologist.
And if I have
that
to
I totally agree.
if I have to refer test, then I ask for a LFT, I ask for a HbA1c, and I ask for a lipid profile.
And blood sugars, yeah.
How well do these correlate?
Dyslipidemia and everything. So
how well do these biochemical tests correlate with what you find actually in terms of LFT or lipid profile?
So in fact, nowadays I am also mentioning pancreatic fat. So there are so many patients, when I see some pancreatic fat, I ask for a HbA1c and it is raised. They are pre-diabetes.
In terms
so
of
pancreatic fat is also one thing which can.
Yes.
Yeah, it's a big thing.
Pretty
Pancreatic fat is now big.
Yes.
And
that's,
a lot of these patients are asymptomatic and they are pre-diabetic.
Yes. In terms of reversal, would you what do you think that grade 2 can reverse with modification of lifestyle factors or a period of time? Is that possible? Or is it an inevitable progression through stages to reach cirrhosis?
So, grade 1 and grade 2 are definitely reversible.
Yes.
So,
Sir, you mean-
when we talk about transient elastography and MR elastography, transient elastography is if the patient is cirrhotic, their results are good. So, now the thing is they have the transient elastography machine beside them. So they get a patient, they suspect, they do the transient elastography, they get cirrhosis, everything is sorted out at the same time. Their limitation is differentiating grade 1, grade 2, grade 3.
Yes.
So what my gastroenterologist told me that I know that your MR elastography is best and I myself see that. But then there is a chain of event. You send, then they get MR appointment after 24, 48 hours. Then they come, it takes 3-4 days. So he said it's very practical for me. Do elastography. If I get cirrhosis on it, we move ahead for the treatment. But then, so they send patients to us where they transient elastography is not right, what they are expecting, then they send for MR. So I think we'll have to work out a plan, something like this, so that, you know, they are also happy, we are also happy, and the patient is also getting the right treatment.
But we can use these modalities, ultrasound elastography and all, we can use for the mast cell patients. In our center, what we're doing is for the mast cell patients, when we see the fatty liver, we'll use the ultrasound, the shear wave elastography, and we'll mark the values, and then we'll send to the mast cell physician. So he will take the call and he will send to the gastroenterologist. So at that time itself, we'll finish the shear wave elastography, so that we can grade the.
One question. Our referral patterns pyramids usually work with the gastroenterologist, but is it necessary to expand that to a more multidisciplinary approach where we include other aspects of the metabolic syndrome also into the picture?
Yes, yes.
So we can rope in
Probably.
physicians, and as Dr. Sharad just said that the cardiologist should be hepatologist first, so we can rope in cardiologists even. So they are very pally to us.
Endocrinologists are very important here.
Yes.
Endocrinologists.
Endocrino people,
So
cardiologists, endocrinologists, general physicians.
So when I say LFT, automatically gastroenterologist come into picture. When I say lipid profile, if it is abnormal, cardiologist will come in the picture. HbA1c, the endocrinologist will come in the picture.
Yes. So that's a referral pattern that must be counseled and emphasized also to the patients, that you might have to visit multiple specialties and not limit to just a single standalone
So I
specialty.
think what Dr. Anjali is saying, she counsels and then she can refer those 3 tests to be done, and then, you know, she can evaluate at her level, and then
Grade 1, I'm doing that, but grade 2, grade 3, I feel that will be a disservice to the patient. I refer them grade 2, grade 3. But grade 1, I'm doing that. I've been doing that for the past 1.5 years, and it's working. I mean, that works fine for a standalone clinic like mine. But I keep in mind that I don't incite my referees if they are physicians. I don't do that then. I just write and send. But if they are gynecologists, because mainly my referrals are gynac, I'm more into women's imaging. Then I go ahead and counsel them. Then that you have to be judicious in a private practice like mine, in a standalone clinic. In an institute, that is okay because then it's a synergy happening. But in my practice, so for the viewers, they have all kinds of people are there. So for the delegates, so I think you have to little bit use your brains in that. But stage 1, we can, I think, that can be done.
What are the lifestyle modifications that you would advise, or the strategies to address modifiable risk factors?
So increase physical activity, reduce consumption of empty calories.
Is there any
reduce
single modification that is easy to do?
Alcohol, restrict alcohol.
Alcohol is easy to drink, not to stop. Is there anything that is easy to stop? All of them sound good to hear, but then when you start practicing it, it's very, very difficult to actually sustain that and reach a level where you have a impactful change. So what are the things that we can tell them, and how do we monitor to see that it's actually making a change?
Monitor, you have to call them back and monitor by biochemistry and maybe ultrasound.
No, if the patient is affordable, we can go for the CT. As Dr. Sarah said, the liver attenuation index, we can measure it. If the patient is affordable, we can go for MRI, or the CT also we can measure. And they have to reduce the cost.
CT scan would be fine also.
Yes, the plain scan, the upper abdomen plain scan, we can just do and measure the liver attenuation index.
And how soon do you expect that might change in either direction? either for the better or for the worse.
So here in our center, the hepatologist is doing after 3 months.
3
If
months.
somebody wants to donate the liver, if there's a mild fatty liver or moderate fatty liver, they're asking them to do all the lifestyle changes and then come back and
3
review it
months.
after 3 months.
Yeah. That's what my experience.
So would 3 months be sufficient to make an impactful change?
Yes,
Or? Yes.
So grade 1 changes, sir.
Grade
They
one.
give vitamin E also. I don't know why, what's the rationale
Vitamin
behind,
E
but
is
they give
given for fatty liver, yeah.
for fatty liver. Vitamin
the-
E and Udilip combination, I think.
But
they give.
now there are medications which are giving, means we have patients who have actually reversed and going back to normal.
Yeah, going back to normal. Yeah.
Is there a goal like for, let us say, weight loss is considered to be something that's very good for reversing fatty liver? Is there a goal about how much weight loss in what period of time? And are there goals like that when you look at modifiable risk factors?
We don't know. But as a starter, just 5 kilos of weight loss can be, because we have seen potential donors who have some fat. They come in like 2 to 3 weeks and their fat is gone.
Mainly restriction of maida and packaged products helps a lot. And some activity, at least 1 hour per day for 5 days a week. That's what I recommend.
I remember reading somewhere that I don't remember the exact citations, but a 10 kilogram weight loss for a period of 3 to 6 months can make a certain percentage of change in the indices.
Yes, yes.
And
it's
so
about you are going to reduce by 10%. They used to say the triglyceride will reduce by another 20%.
something like that. And then even when you're doing the imaging, you're starting to see that change that's there in terms of quantification and things like that.
Most important is to correcting insulin resistance.
Yes.
Yes.
And the physical resistance, physical activity plays a role. I think its
Because,
primary role is through insulin resistance and reducing hepatic inflammation, and thereby contributing to the changes that we are seeing. So even in terms of working on the pancreatic fat, so weight loss and physical activity are ways that can help with that.
In radiology, our difficulty comes in the differentiation of the NAFL in the sense the steatohepatitis and the liver disease, fatty liver disease. In that part, we are not having a definite cutoff criteria to say that this patient has come to the stage of NAFL.
If their transaminase levels are high, there are cutoff. So if you have fatty
So
liver,
5 times, I think, no?
Fatty liver plus raised transaminase, then
Yes,
you can call it as
exactly.
Sir,
NASH.
is there a cutoff to the level of transaminase? Is it 5 times or something like that?
1 second, let me see. Probably it's there in my presentation.
He said 2 times in a slide.
2 times, okay.
AST,
I'm not sure.
ALT,
I've just
2
started.
times.
2 times.
2 times, okay. They've
It is
been,
so weird,
they've
No, I meant the radiology criteria. We have to combine the lab parameter.
compared the lab parameter.
So even if you have mild increase in transaminase with fatty liver, then it is going into
It's going for the inflammation.
hepatitis.
Yes.
Yeah. So MR elastography tells you about hepatitis.
For ultrasound elastography, hepatitis is a confounding factor.
So diffusion weighted imaging plus MR elastography tells you about the inflammation.
Now, the role of alcohol, especially considering that it's a silent epidemic and a not so silent epidemic in some states. So how does that confound the whole scene? Does it make sense to have a differentiation between an alcoholic liver disease and a non-alcoholic liver disease?
See, at histopathology level, there are not much differences. And both means the fat comes there because of diabetes or because of alcohol. Finally, the action, inflammation, the process is same. So history is the key here.
For
Plus,
metabolic, yeah.
there are certain lab values like reversal of AST, ALT, more of GGT can give you a insight that this is alcohol related, but they are not all 100%. So now, but this becomes beyond our scope. So, but we have identified, because patients don't tell alcohol. So I have a habit to look at the LFTs. So I've so many times called the gastroenterologist, see, I am getting this LFT and this is fatty. Just check about alcohol. Because patients obviously don't say that many times we are having alcohol. I'm sure they also look into that, but I'm saying proactively I'm calling them when I'm looking at the scan. Because they order CT, LFTs at the same time. So we see the results before they see. But that's possible only when you're limited group at a under the same roof.
Sir,
If
you
you
have
want
to
to,
unmute.
yes, I unmuted. If you want to increase the awareness and the clinical practice patterns around MAFLD, then how do you suggest we go about it?
Sorry?
How do you suggest we go about it if we want to increase the awareness and the application, clinical application of practices?
radiologist?
For a radiologist, yes, for a radiologist in a
We
standalone.
synergize more with the physicians.
It's most important is you getting interest in it. Number one, you get the passion for it. Number two, you read a little bit. Number three, you keep interacting with your referring colleagues and attending conferences and all that. That's how. But if you don't have interest, somebody who is interested more in MSK ultrasounds also sees some liver. Okay, I'm not interested. My focus is on MSK. Then I may not do all that exercise of referring the patient, doing the LFT. So it's a very individual thing. You have to have passion and in yourself for that particular thing.
We can increase awareness in the local groups, like for example, in some cities, Lions Club and things like that. We can do that. We can because for abdomen there are a lot of self-referrals. For OBGY there are no self-referrals, but for abdomen there are lot many self-referrals which are happening. So in general, we can do columns in newspapers and making them aware about this modality, about elastography, about quantification, and then amongst ourselves we can like if a patient comes for an ultrasound and I find grade 3 fatty liver disease, I can ask for an MR quantification. So that way we can do that. I mean, once the patient comes to a radiology clinic, then we should ensure that the diagnosis is made and then he gets the requisite counseling and the medication needed. So we for that we'll have to create social awareness, and maybe, as sir said, that it's high in priority list of the government, the fatty liver disease. So maybe some policy change and on the part of the government might be required.
Can I take leave? I have to go home now. I'm getting
Yes.
phone calls.
Yes.
Bye.
Bye then.
Bye.
Thank you so much.
Bye,
Thanks,
Dr. Sharad.
Thank
Thank
you.
you for that
Bye-bye.
informative talk.
Yeah.
Bye.
The thing is actually, as Madam said, you have to create the awareness. You have to spread the awareness among the people about the fatty liver. Then we have to incorporate the ultrasound parameters, no, the quantification parameters. Then it will be easy to quantify, and then we can refer the patient to the hepatologist.
There are two advantages of quantifying. At least when the patient comes back to you after 3 months, you know you have a number to for him to see whether it's effective or not. So that's why quantification, I feel, I mean, and now it's available in many mid-end and high-end machines, all I
Yes,
think
yes.
having quantification.
And there are so many papers are coming out that it is comparable to the PDFF also. So when it's
PDFF
comparable,
and then it takes only 5 minutes because not even 5 minutes. It takes only 1 minute because we have to take only 5 readings. For elasto, we have to take 10 readings. For this, we have to take 5 readings and calculate the median only. Take the
yes,
median of the reading. So
exactly.
we don't have to do much. It doesn't take much time. So for myself, I give HRI and TAI, TSI for all my patients. I
Okay.
do that for the fatty liver patients, not all.
And there are so
So
many standalone centers are doing the master checkup by themselves, along with some lab, combining with the lab they're doing. So for those, see here, the point here is the preventive program means we have to identify the fatty liver as early as possible.
mm,
So again, we have to turn ourselves into the clinician. That's the motto, no?
that's the need of the hour. We have to
Yeah,
reclaim, as sir rightly says, has been saying for past 4 years, reclaim your position as physicians and not as
yes,
merely
exactly.
ultrasound technologists or something like that. So
If you're able
that's
to
what
do that, then we can get more patients as well as we can serve the society also.
that's true.
Dr. Mandal, any comments from your side?
Sir, you have to unmute yourself.
Think to. Okay.
Share that.
So please unmute yourself.
Dr. Vijay is also there.
Hello.
Yes,
Yes,
Can
sir.
you hear me, sir?
yes.
Sir,
Yes, sir.
actually,
Loud
I
and
fully,
Praveen,
yeah,
it
I am
seems there
fully
is some
agree
connection
with.
issues.
Hello. Hello.
Yes,
Yes,
yes.
sir.
Hello.
Please
I
carry
am
on.
fully agree with you, Dr. Anjali. And invariably, I have taken at least daily 8 to 10 patients of abdomen ultrasound. There are at least 6 or 7 patients suffering from fatty liver.
Absolutely.
Uh, but the you same, I advised him because I am working last for 30 years and being a senior member of ERI chapter, so I can advise the patient also and send recommendation to the physician. Sir, you look, this patient is suffering from this and this. It is better to avoid all fatty things and particularly maida, chowming, and this pizza, burger, so many things, fast food, and alcohol. But what happens? Bihar is not alcohol is not allowed, but everyone take the alcohol in the night. So the patient actually what happens? The some patient told you have to my ultrasound. Why you suggest me? I'm better go to the higher center or anyone if my doctors advise me. But for awareness that like the breast cancer, we do so many seminars and awareness to the people. And this is also at present very needful to our so to save our people and save our society. So we are fully agree with Anjali that this awareness through Rotary Club or any club or any government media, non-NGO, so many things. So we can help our community, sir.
We can have short video clips like Dr. K.K. Agarwal used to do in COVID times. So we can have small clips and post it on our local TV network or something like that.
There are no further questions. I will invite Dr. Anjali to conclude the session.
I would first of all like to thank the IRIA Bihar chapter and especially Mandal sir for this interactive session on preventive radiology. Also, I would like to thank our Viju sir and Praveen Nirmala sir for this opportunity. Also, to Dr. Sharad for such an informative talk. And with this, I conclude, and with the line that we have to reclaim our position as clinical physicians rather than being just technologists. And for every patient whom we find that we have a fatty liver, we should at least counsel them and let them know that they have a problem. Because many a times we just write it down on the report and the physician will see if she's suffering from a ureteric stone. They'll just tell her that you have a ureteric stone and treat for that, but they totally disregard fatty liver. So that is what we have to just tell them in a single line. That is what I do. That see, you have a chance, maybe only a 5% chance, but you have a tangible chance of getting a CLD later on in life after say 10 years or 15 years. So you better modify your lifestyle. So that is the key. That is the key which we have to keep in mind while doing that camera.
Dr. Venkatesh, concluding remarks.
That's what, as we are discussing, we have to increase the role of radiologists, particularly in the preventive programs. So the one main aspect is the fatty liver disease. So this is going to be the game changer, even for the standalone centers to claim their position. So we have to work on that.
So
and
then,
thank you for the organizing team for giving this opportunity.
thanks to all of you. Thanks to Dr. Mandal. Thanks to Dr. Anjali, Dr. Venkatesh, Dr. Sharath, who had to leave, Dr. Rijo, who is facing network issues, and to the team at ClearNet. And hopefully the audience has got some learning points that they can act on, and hopefully they will act upon it. And soon we can see a change in the paradigms of radiology practice, especially with reference to liver diseases in India. On that note, thanks, good night. Have a safe trip home.
Good night.
Have a
Good
safe
night to all
night.
of you and delegates also. Okay, good night, sir.
Good night. Have a safe drink, those who want it.
Thank you.
Thanks.
Thank you so much, everyone, for letting us host the session today. I hope you all had a seamless and hassle-free experience. So with all your last comment, we are concluding the session over here and really looking forward to hosting all again. Thank you so much and good night to all of you.